In this video, we're going to cover the cardiac murmurs commonly tested on Step 1 and Step 2. We'll focus in particular on the aortic and mitral murmurs, the septal defects, how changes in preload and afterload affect the murmurs, and also HOCM. There are no disclosures. We'll start with HOCM, which is short for hypertrophic obstructive cardiomyopathy. The pathophysiology here is that in a normal heart, you can see the mitral leaflets here. Blood is flowing from the atrium to the left ventricle and then out the aorta. With HOCM, the IV septum, this area over here, is way too large. So here it's normal. Here it is large, and it's pushing against this leaflet of the mitral leaflet, and it's preventing blood flow from getting to the aorta and the rest of the body. So classically, the test question will describe a teenager playing sports and suddenly collapses. Think of HOCM. It's an autosomal dominant disorder. Here's a picture of a famous soccer match in 2002 where one of the players who had HOCM collapsed in front of the entire field. Aortic stenosis comes up very often. The valve over here is stenotic. The lumen isn't as wide as it should be. And they like you to know that if you're under 70, it's likely a bicuspid aortic valve, whereas if you're over 70, you usually have a normal valve and it's just secondary to aging. Also, because the valve is stenotic, it doesn't close as harshly as it normally will. So the S2, the second component of the heart sound over here after the crescendo decrescendo murmur, this S2 is going to be softer. Again, the aortic component of the S2 is going to be softer. Aortic regurgitation is a diastolic murmur, meaning you hear it during diastole while the heart's relaxing, and anytime you hear a murmur while the heart is relaxing, it is pathological. So here the blood should go from the left ventricle to the aorta, but when the heart starts relaxing, it goes backwards. The test question may describe a pistol shot femoral pulse, and the patient may have a widened pulse pressure. Mitral regurgitation and prolapse, I put these two together because the main cause of mitral regurgitation in the developed world is secondary to mitral valve prolapse. So here we can see the blood should go from the left atrium past this mitral valve into the left ventricle. With mitral regurg, just like before, it goes backwards. And you also have this prolapse, which if you look at the valve over here, it looks like an umbrella, and it's popping back into the atrium. So that's the prolapse. If this gets severe enough, you may need to get surgery. Mitral stenosis is similar to aortic stenosis on the mitral valve, where it's too narrow, and so you could hear the turbulent blood flow. One of the main causes for this is secondary to rheumatic fever. After you get a strep infection, you could get rheumatic fever. You get the Jones criteria, the joints, the heart, the nodes, erythema marginatum, and the Sydenham's chorea. If you have a patient who had rheumatic fever, they need monthly penicillin shots because they may have structural heart disease. So it's kind of a prophylaxis. This chicken over here, this rooster here, reminds me of earliness. And that is that as the disease progresses, the murmur gets earlier and earlier. The ice cream I put down here is to remind me that my sister, when she was pregnant, she loved to eat ice cream, and so this is one of those murmurs that when you're pregnant, this murmur gets louder. Atrial septal defects, the right atrium and the left atrium, there is a hole in between them, and so normally when you have a clot in the venous system, it can't get to the arteries because it needs to go through the lungs, and the lungs won't allow a large thing to get past them. With atrial septal defects, though, you can get a clot in the venous system, and it'll bypass the lungs, go straight into the arterial system, and then you can have, for example, a stroke. So they may describe a paradoxical embolism, and classically this murmur presents as a wide and fixed S2. Here I did a kid playing. It's important to remember this murmur is fixed. Because pulmonary stenosis also has a wide and split S2, but this one is fixed, meaning that it doesn't change with inspiration and expiration, whereas pulmonary stenosis, that one is not fixed. It will change with the breathing cycle. Finally, preload and the changes it does. Increasing preload means you're adding more blood to the heart. So there are a couple of ways of doing this. One is the leg raise. You can see over here, if you're lying down, the blood is not returning as quickly as it would when you lift your legs, and then gravity's going to get all that blood to quickly return. Another way to increase the preload, or again, increase the amount of blood going to the heart, is squatting. You can see the blood in the feet is going to take a while to get all the way to the heart. If you squat, the distance is a lot shorter, and it will return to the heart a lot quicker. When you increase preload, you're adding more fluid to the heart, so if you have a problem in your valve, you're more likely to hear it, right? If there's more fluid passing this bad valve, you're more likely to notice it. The exceptions to that, the famous one is HOCM, hypertrophic obstructive cardiomyopathy, and the reason for that is, if you remember the pathophysiology, is that the mitral leaflet over here is pushing against the septum. If you increase your preload, you have more blood flowing through this area, and so it keeps the valve from collapsing onto the septum. Another exception is going to be mitral regurgitation, because there's going to be a higher pressure in the atrium. The blood is not going to want to return as it normally does. Increasing afterload, I included this picture because I haven't seen one of these in forever, and they're awesome. But essentially, you're doing a hand grip, so now the blood needs to, the heart is pushing against a harder system. The blood, the muscles are squeezing on the arteries, so the heart needs to push harder. And so this will normally decrease the murmurs. The exceptions to this are regurgitating murmurs. Any regurgitating murmur is going to be louder with an increase in afterload. I added this picture of the stomach just to make it a little more intuitive, that if you block the outlet over here, it's going to try to back up, right? So if you already have a regurgitation and you block the outlet, the aorta, it's going to back up, and it's going to even increase the amount of regurgitation. Another exception to this is the ventricular septal defects. The blood with the VSD may flow from the left ventricle out the aorta, but if you increase the afterload, there's a lot of pressure in the aorta, and now it may try to preferentially go through the septum into the right ventricle. So this murmur also is louder with an increase in afterload. That's all. I hope you gained something. If you have any questions, feel free to ask, and I'd be happy to get back to you as soon as I can.